morning, students. I am Dr. Javed Jameel, Associate Professor from the Department of Orthopedics, and today I will be discussing a very important topic with all of you, that is examination of the knee joint. As we all know, knee joint is the largest joint of the body. It is a type of modified hinge joint. What is a hinge joint? Hinge joint is a type of joint in which plane of movement is single, that is flexion and extension. While in knee joint, there is a slight lateral rotation also occurs at the tibiofemoral joint. That's why it is known as modified hinge joint. Now the knee joint has three joint surfaces: the medial femorotibial, the lateral femorotibial, and the patellofemoral joint. All these joints combined form three compartments of the knee joint. Now the examination of the knee joint starts from inspection. First of all, we have to observe the gait of the patient. We ask the patient to walk on a flat surface, and we observe the gait of the patient from the front, from the side, and from the back. Next, we will look after the alignment of the knee joint. We have to check where there is any deformity of the knee joint. The deformity may be angular or rotational. Next, we will look for any swelling around the knee joint. We have to look for the bulge of the patella, the parapatellar surface. Then we have to look for the swelling over the popliteal region or on the sides. Then we have to observe for any surgical scar or presence of any sinus or skin eruption on or around the knee joint. We have to also see for any wasting of the quadriceps muscle, and we have to observe any obvious lesion in the popliteal fossa. Means we must never forget to examine the popliteal fossa. In this picture you can see on the left side both the knees are going outward and the legs are deviated inward. So the left side picture shows genu varum deformity. In genu varum, the legs are going inward. On the right side, you can see the one of the leg is deviated outward or laterally. This is genu valgum deformity. L for L. Lateral valgum. Medial varum. So if the leg is going medially, this is genu varum. If the leg is going laterally, this is genu valgum. Now observing the same deformity from behind, you can see both the legs are deviated inward. So this is genu varum deformity of both knees. This is very common finding in advanced stage of osteoarthritis of the knee. In this picture you can see that the leg is deviated anteriorly. So this type of deformity is known as genu recurvatum deformity. Recurvatum, in which the leg is deviated anteriorly and the popliteal fossa is more prominent in this deformity. So the causes of this deformity includes generalized ligamentous laxity, the laxity of the posterior structure, specifically the posterior cruciate ligament or the posterior capsule or hamstring muscles. Now you can see this is reverse deformity. So this is the flexion deformity of the knee joint, in which the anterior structure are more prominent and the knee is flexed to around 90 degree. This type of deformity is very common in infective arthropathy of the knee joint, namely tuberculosis of the knee joint or advanced stage of rheumatoid arthritis or other type of inflammatory arthropathies. In this, you can see that there is excessive swelling over knee joint. So we are looking from the front. You can see that the size of the left knee joint appears large. The skin is more shiny on left side and there is huge swelling present over left side as compared from the right side. So such type of swelling may be present in synovitis or in any infectious condition also. Now in this picture you can see there is localized swelling present over the right knee joint, mainly localized on and around the patella. So this type of swelling may be present in prepatellar bursitis, in which the collection is mainly localized in the prepatellar area and the swelling is predominantly in the patella and not involving the knee joint proper. Same you can see in flexion deformity of knee flexion position of the knee joint. You can see the swelling is more prominent, predominantly around the patella, watching from the front with knee in flexion, and this is watching from the side. There is well demarcated swelling present all around the patella, characteristic of prepatellar bursitis. Now compare this from this picture of a normal knee joint, in which you can see that the bulge of the patella is clearly visible and the parapatellar hollowness is visible clearly. So such type of knee joint is of a normal knee joint, and if you can flex the knee, then you observe that the fullness of the patella is gone in flexion because the patella lie in the intercondylar notch and the patellar bulge become vanish in flexion. So this is a normal finding. Now on the left side picture you can see there is excessive aspiration over the dorsal skin of the leg and knee, a characteristic of psoriasis. On the right side picture you can see that there is a sinus present inferior to parapatellar area, a sequelae of septic arthritis of the knee joint. Now what you see on the left side knee, that there is redness, swelling on the left side knee as compared to right side. You can see the parapatellar fullness is there along with erythematous skin and shiny also. So this type of presentation is characteristic of infective or traumatic knee in which there is bruise. So these findings always have to be confirmed on palpation. Another picture of thighs of both sides, you can very well observe that the right side thigh is well wasted as compared to left side, and there is also swelling around the right knee joint. So whenever there is disuse of the knee joint, there must be obvious wasting over the thigh muscle if the condition is chronic. Now we have to move to palpation. In palpation, all the infective findings has to be confirmed. Now one important test in palpation is how to palpate the joint line. So starting from the uninvolved side to the involved side, we keep the knee in 90-degree flexion and palpate from midline outward on both medial and lateral joint line, uninvolved to involved side, then center to lateral and center to medial on both the side, and look for joint line tenderness. Now joint line is tender in most of the meniscal pathology, also in osteoarthritis of the knee joint. Now if the patient has swelling over the knee joint and you suspect that this may be due to synovial hypertrophy. As you know, synovium is a soft structure and it has doughy feel. Doughy just like atta. So doughy feel can be very well palpated by insinuating your finger, keeping the knee in extension position or semi-flex position. So keep the knee in 5 to 10 degree of flexion and insinuate your finger into the synovium and feel for the doughy feeling of the synovium. This type of feeling is very common in tuberculosis of the knee joint, also in various other causes of synovitis. Now to check if there is fluid present inside the knee joint, there is a test known as Patilla tap test, also known as ballotment test. In this test, we ask the patient to keep the knee in full extension, to relax the quadricep muscle. Then we squeeze the suprapatellar pouch so that the fluid may come on and around patella. Then we gently press the superior surface of the patella so that it hit the femoral condyle and again rebound back to our finger. This indicates that there is free fluid in the knee joint. Patella tap can't detect minimal fluid collection in the knee joint. So for this test to be positive, the patient should have moderate to severe fluid collection in the knee joint. Now in the patella, we also have to check for patellar grating sensation, which is the vibrating sensation which we feel in our finger when the patella rub against the femoral articular surface. Then we have to check for a facet tenderness of the patella, which may be tender if there is medial patellofemoral ligament injury due to patellar dislocation. Then we also have to check for cryptus. This cryptus may be felt if there is fracture of patella or there is any foreign body between the patella and the femoral condyle. Now along with this, we have to palpate the femoral condyle, the proximal tibia. We have to look for any bony irregularity or bony swelling or iliotibial band or any soft tissue undue prominence. Now coming on to the movements. As I have previously mentioned, that knee is a modified hinge joint in which the primary motion is flexion and extension of the knee joint. Along with this, there is slight lateral rotation also occur in the knee joint. So in the movement, we have to check the range of the movement of knee joint. The normal range of knee joint is from 0 to 130 degree. We have to also check whether this range is painless or painful. Then we have to check for the extensor lag or any fixed flexion deformity of the knee joint. This question is commonly asked that what is the difference between extensor lag and fixed flexion deformity. So both these conditions have knee in a particular degree of flexion. The main difference is in extensor lag we can passively correct the knee deformity and the knee will reach its zero position. While in flexion deformity, we can never achieve 0 degree position of the knee joint, or in flexion deformity, extension is not possible at all. Now this is the most important part of the knee examination, that is the special test. We have a number of important special tests, namely the stress test, the test for meniscal injuries, and test for ligamentous injuries. So, first of all, have a gross idea about the stability of the knee joint. In this video, you can see the knee appears flail in almost all the motion of the knee joint. Initially, the patient shows recurvatum deformity, and this is also lag in both medial and lateral plane. Once again, see, this is recurvatum deformity, means posterior structure are gone. Now this is valgus stress test, and this is varus stress test. This is valgus and this is varus. So the posterior structure, the medial and lateral, all structure are lax in this case. Now this is valgus stress test. Keep the knee in 10 to 20 degree of flexion, and one hand hold or support the knee, and the other hand of the examiner hold the distal part of leg in 20 degree flexion of the knee joint, and we give valgus stress to the leg. If there is opening on the lateral side, or if there is opening on the medial side on valgus stress test, then this means there is deficit medial collateral ligament, and vice versa. If there is opening on the lateral side on varus stress test, then this indicate there is laxity or tear of lateral collateral ligament. Now we have to check for posterior structure integrity. For this, we have to lift both the leg one by one and check if there is recurvatum deformity developing or not. As you can see on the right side, there is laxity of the posterior structure, namely the PCL, the posterior capsule, and the hamstring muscles. So on the right side, there is recurvatum deformity on lifting the leg, while on the left side it is normal. Now another condition which came to our OPD is locked knee. Patient usually give a history of some sports injury, or after that the patient has sudden locking of the knee joint at some degree of flexion, and patient is unable to move the knee, and the knee is fixed in a locked position. So how to test? First of all, you demonstrate on the normal side, there on extension, there is certain recurvatum deformity is developing. This is normal. While on the right side, the knee is flexed and there is no motion at all. This indicates that the knee is locked. Now we have to check for meniscal injuries by McMurray's test. In this, the knee is keep flexed, limb is still rotated, and a valgus stress is applied over the knee joint, and the patient will have sudden popping sensation or pain on creating the rotation. Now another important test for meniscal injury is the Appel's compression and distraction test. The important point is to remember is that this test is done in prone position with the knee kept in 90 degree flexion. Now the examiner applied compression along the axis of the leg and rotate the leg medially and laterally. Similarly, the surgeon applied distraction over the knee by keeping his knee on the patient's popliteal area, Now rotate the leg medially and laterally. If there is pain on medial rotation, then this indicates lateral meniscal injury, and if there is pain or popping on lateral rotation of the leg, then this indicates medial meniscal injury. Now another test for ligamentous integrity is the anterior drawer test. In this test, the knee should be painless and the patient should lie supine with 90-degree position of the knee joint. The examiner hold the knee by one hand and keeping the thumb of both the hand on the front part of tibial condyle and observe the anterior translation of the tibia. If there is 2 mm anterior translation of the tibia beyond the anterior part of the femoral condyle, then this test is positive. Also, if overall the translation is more than 10 mm from posterior to anterior, then this test is also positive. Another important test to check the anterior cruciate ligament injury is the Latchman test. The significance of this test is that this can be done in acute injury setting also. For drawer test, the knee has to be painless, while for Latchman test, this is not the prerequisite. We ask the patient to lie supine with 15 to 20 degree of the flexion at knee joint. The examiner hold the lower part of thigh from one hand and the upper part of leg from other hand. Then it try to translate the leg anterior to thigh and check for translation of the tibia. A positive Latchman test is a clear indicator of anterior cruciate ligament injury, and this test is more specific than drawer test. Now to check posterior cruciate ligament injury, this test is known as posterior drawer test. In this test, first of all, we keep the patient supine with 90-degree flexion of the knee joint and check for the tibial translation posteriorly. If the tibia is translated posteriorly, then there is sagging of the leg present, and this is known as sagging sign. Now to perform this test, the examiner hold the upper part of leg and keep both the thumb in front of tibia just like in anterior drawer test and give a posterior push to the upper part of leg. Any deviation of more than 10 mm or a soft end indicate posterior cruciate ligament injury. Now another important test is the pivot shift test. This test detects the integrity of anterolateral structures. What are the anterolateral structures? The anterior cruciate ligament, the lateral collateral ligament, the arcuate ligament, and the posterolateral capsule. So the position of patient should be supine, keeping the knee fully extended. The examiner give interrotation at the leg along with valgus at the knee joint, and at the same time the examiner flex the knee from extension to flexion, and there is sudden giving away of the joint. So on the first part of this video you can see that the surgeon performed the Latchman test, and this is the pivot shift test. Again I repeat, in pivot shift the knee should be extended, interrotated with valgus stress along with movement from extension to flexion of the knee joint, and we check the subluxation of the tibia over the femur. Now at the end, we have to do the measurements of the thigh to check for wasting, which may be obvious if the condition is chronic. And we have to check for the Q angle, that is also known as the quadriceps angle. What is Q angle? It is the angle between the center point of patella and anterior superior iliac spine and the mechanical axis, which is a straight line from center of patella to the center of hip joint. So if there is genu valgum deformity, then Q angle will increase, and if there is genu varum deformity, then Q angle will decrease. This summarizes your presentation of the